Hello, this is Chelsea Marks for VETT 221 Task 6, and we're going to go over anesthetic monitoring using an anesthetic monitoring chart. First thing I'm going to explain is what this video is going to cover. So we're going to go over heart rate and rhythm, we're going to go over blood pressure, mucous membrane color and CRT, respiratory rate and rhythm, and body temperature. So those are the parameters we're going to be monitoring, as well as end-tidal CO2 with our little capnometry. The second part of the video, we're going to go over the anesthetic planes, the stages and planes of anesthesia, and how they pertain to the reflexes that you're going to see in your patient regarding how light under anesthesia they are and how deep under anesthesia they are. So going ahead, and first part we're going to explain is all of our monitoring equipment. So I have my patient here, my little giraffe, tied down as a visual aid so we can go ahead and see the equipment in use, even though it's not going to actually work, but we can see it in use. So first thing I want to show you here is that we have our patient properly intubated, and we're going to connect to the anesthesia circuit here. So we have a little patient, so we're going to be with this non-rebreather. It's under 7 kgs. First thing I'm going to hook up here is the ECG leads. So they're really important in monitoring the heart rate and rhythm. So we have our white lead here. So white goes on the right, and this is the right side of the patient over here. So we're going to go ahead and clamp that down. And then we have our red lead here, and red is the left inguinal. And we have our black lead, and black is the left axilla. So we have those clamped down, and with those wet with a little bit of alcohol, you would see a rhythm, an ECG, on our machine over here. I'm going to zoom in. So here's our Cardell machine. So I'm going to go ahead and point out a couple features here. So the top line here is our ECG. So that's where you're going to see your nice QRS complexes going across that green line there. The second part here is our end-tidal CO2 capnometry. Over here we're going to have our SpO2 number, which would be with our pulse ox clamp that we put on the tongue. Down here we're going to have our blood pressure, which is systolic, diastolic, and mean arterial pressure. Up here we're going to have our temperature probe reading. Right now it says 65.8 because we're just sitting here in our room. If that was in a patient, it would be you know, reading their actual body temperature. So that number you want to see anywhere between, you know, 98.5 all the way up to 102 would be a normal temperature in here in surgery. Depending on how deep they are in their anesthetic and how long they've been in their procedure, the patient's going to become hypothermic the longer they're under the isoflurane. So those are our monitors over here. So I'm going to zoom back out and show you the placement of a few of those monitoring devices. Okay, so we're back at our patient here who is hooked up to the ECG with the leads. Second thing I'm going to put in here is our temperature probe. So we have an oral temperature probe here. Some clinics might use a rectal probe, but this is oral. So we go ahead and we lubricate that with a little bit of sterile lube, and that goes down, sits kind of right next to the ET tube, but it actually goes down the esophagus. It's going to go down to about here on the patient, and it's going to lay right next to the heart, so you get a really good consistent reading there of the temperature of the body here. So next thing we're going to put on here is our blood pressure cuff. So we have a lot of different sizes of blood pressure cuff, all the way from the largest dog here, which is a size 8, which is more like your pit bulls, your shepherds, your larger breeds. So we have size 8 all the way down to size 1, which is your tiny little kittens that barely fits on your pinky here, so they have tiny little feet. This patient is going to take a size 5. I'm going to show you here that the patient's limb needs to fit in this range right here. So when you circle out around the limb, it needs to be within that range. So we're going to choose a size 5 for this patient and hook that up. So blood pressure, like I said, is down here on the monitor, the red area. So you get systolic, diastolic, and mean arterial pressure. Mean arterial pressure is really important to organ perfusion. So if the blood pressure is too low, the mean arterial pressure is going to also be too low. If it's below 60, it means your organs are not getting perfused with blood. So kidneys, liver are not getting enough blood circulation to keep them functioning. So you could actually cause permanent damage in the patient if the mean arterial pressure is below 60 for too long. So we watch that mean arterial pressure really closely. So the next part of the monitor that I'm going to put on here is our esophageal stethoscope. So we have this handy dandy little stethoscope that we also lubricate and stick down. This is going to also go in the esophagus. This little guy sits also next to the heart. It's going to sit right up at the midline, and it takes a really good heart rate. So you can stick these in your ears just like a normal stethoscope and take a listen to the heart. What's great about these is they're very non-invasive, and you're usually out of the way of the surgeon. So when you have your regular stethoscope here, like I have, put those in your ears, you might be in the way of the surgery. So if you're reaching into the sterile field, surgeon's not going to like that. So this esophageal stethoscope is great because you're out of the way of the surgeon for the most part of the time, unless they're doing a surgery on the mouth. This is going to be a great non-invasive way to hear heart rate. You can hear a really, really strong, really good heart rate through these because it's sitting right next to the heart. So the last piece we're going to hook up here, second to last piece, is our pulse oximetry. So we have a little pulse ox here, just like a human one, but this is a clamp, so you can put it on a tongue, you can put it on a prepuce, you can put it on the ear, a toe, sometimes people even use a vulva. It depends. It just has to be a really light colored piece of skin or the tongue. So we're going to go ahead and put it on the ear here since this patient doesn't have a tongue. So we're going to clamp that on. So the white little side of that clamp goes on the underneath, and that would give us our pulse ox reading. So SpO2 here is going to give you a good reading of how well the patient is perfusing their tissues. So how well they're oxygenating. If we're ventilating them properly, they're going to be really well oxygenated. So the second part of that is our mucous membrane color and our CRT. So in this patient, you would just blanch the gum tissue, just pinch it a little bit, and you're going to watch for the return of the blood to the area. So a normal CRT is going to be less than 2 seconds, and the gum color, the capillary refill time, and the pink mucous membrane color is supposed to be pink, bright pink. Pale pink is okay, but it just means that maybe the pre-medications or the anesthetic that we gave is causing a little bit of pale mucous membrane. So we watch that closely. CRT is really important to us, so we use our eyes as well as listening to the monitors when we monitor patient under anesthesia. So CRT and mucous membrane color. So that's good. The next thing, last thing we would hook up here is our capnometry. So we have our little side stream capnometry probe here that hooks up directly to the endotracheal tube and then to the anesthetic circuit. And then it's going to take a reading of the exhaled CO2, the expired CO2. So the patient breathes out, the little cord here has infrared sensor and machine that's going to read that exhaled level of CO2. So we call it an end tidal CO2 because it's the end of your tidal volume. So that measurement comes back over here. That is going to give us a really good idea of how well we're ventilating our patient, if we're ventilating them appropriately, if they're receiving the correct amount of oxygenation to keep them perfused. So we have to really watch this. It's a really important value to make sure that your tube is correctly in place, that it's not in too far, that each lung is actually expanding. You can use your end tidal CO2 capnometry number to really evaluate a lot of things as far as ventilation goes. So if we're manually ventilating a patient here, bagging them with our little bag, we can tell how well we're doing when we watch that end tidal CO2 number. So that number needs to be about anywhere from 37 to 40. So we're going to draw a little line. It's going to go up, plateau when you exhale, and come down, and then have a little valley. Let's go up again and exhale, and then down to a little valley. So the peak is at our height of exhalation, which should be about 38 to 40. So that's our value of end tidal CO2. not sure I went over the SpO2 number, so that really needs to be anywhere between 97, 98, 99, 100. Obviously with 100% oxygenation being ideal. 98 and 99, you're okay. If I'm seeing 97, 96, 95, I'm going to be checking my monitors. This one likes to fall off a lot, the SpO2 clamp, so I'm going to check my monitors and be checking my patient's other vital signs, just to be sure that it's a mechanical failure and not the patient actually having distress. So last part of this video, we're going to go over the stages and planes of anesthesia and how they relate to the patient. So one last thing we're going to go over here before we move on to that is our heart rate and rhythm and our respiratory rate and rhythm. So those are really important to monitor. The ECG leads monitor the heart rate and rhythm here. So during anesthetic, this is a giraffe, but we usually work on cats and dogs. Cats are going to have a heart rate anywhere between 120 to 140 when they're just sailing on their anesthetic. When they're waking up and they're too light, they're going to have an increase and have some tachycardia. So we watch that, and if I hear heart rate kind of starting to go up, I know that I need to adjust that isoflurane up to another percentage. Dogs, on the other hand, are a little different because they're small dogs and large dogs. So the smaller breeds are going to have a heart rate up to about 180, anywhere from 70 to 120, all the way up to 180. Little dogs are going to have a little more excitement, a little more anxious. They have a quicker heart rate. So it's not abnormal to see a 180 for a smaller dog. Your larger breeds like your Great Danes, your Shepherds, your large Pit Bulls, your Mastiffs are going to have a slower heart rate, even down to 65, 70, 80 during their anesthetic procedure. So if you're seeing the heart rate get too low, you want to make sure, check your monitors, check your leads, make sure they're wet with alcohol because they become dry during the procedure. Check your patient, monitor other vital signs, and alert the doctor that you might think the patient is bradycardic or tachycardic, if that's the case. So we're going to move on to respiratory rates. So we use a ventilator in here, but if we're not using a ventilator, the patient under anesthesia, cats and dogs are also different. Cat's going to need to be anywhere between 16 to 40 breaths per minute. 40 is going to be fast. So if they're breathing 40 breaths per minute, they're probably a little light, they're probably waking up, you need to turn them up a little bit. A dog is going to be anywhere from 18 to 34, kind of depends, also 18 to 40. Again, if they're up on that 40 range, 35, 40, they're probably waking up, they're probably a little too light, so you need to turn up that machine and take a look at other vitals as well. So again, monitors can have failures, and sometimes the ECG leads in here will be giving me a heart rate and rhythm, and they're laying on the table. So you want to use your eyes and your ears as well as your hands, check out the patient, not just what the machine is telling you. So last part of this little video, we're going to go over the anesthetic planes, the stages and planes of anesthesia. So say we just brought our patient in here, we're probably just intubated out in the prep area, so we are going to be stage 2, plane 2. So we're in anesthesia, we are ready for surgery, we're cruising. Stage 3, plane 2. So that is the general anesthesia where you have most surgeries performed, stage 3, plane 2. So ready to open up and ready to go forward. So stage 3, plane 2 is going to have most of your reflexes are going to be absent. Muscles are going to be relaxed. So I'm going to go over the reflexes now. So we have a toe pinch here. So you can't see that. So you can pinch a toe, which is the pedal reflex, and if they pull back, then they're a little too light. We can go over the, can't really see it, but palpebral is going to be on the lateral canthus of the eye here, so you can just tap. That one's going to try to be absent as well if you're under a good level of anesthetic. Corneal reflex we don't use very often, but you take a drop of sterile liquid and drop it onto the eye, right under the cornea, and the eye is either going to stay where it is or sink back ventrally, just a little bit into the head, just kind of sink back. So we don't actually use the corneal reflex here very often because the other ones are really sufficient. Another one we can use here is the swallow reflex. You can pull on the tongue just a little bit, and if the patient swallows, they're too light. Another one here is the ear flick. So you just kind of go along the ear here, tickle the ear, and see if the ear kind of makes a little flick. So that's another good one to monitor, you know, just to see if your patient is anesthetized enough. So jaw tone is important, so you can feel the jaw. If there's jaw tone, then that patient's waking up. So it's another one you can check during your procedure. Last one here, we're going to use just the, you know, looking at the patient and assessing the respiratory pattern. So if their breathing has gotten really rapid and the pattern is just fast, 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 they're panting, that is a sign that they're too light. So that patient needs to be turned up a little bit. So that was stage 3, plane 2. So we're going to move to stage 3, plane 4, which is, stage 3, plane 3, which is deep anesthetic. So if this patient were going to have an orthopedic procedure on a limb, or if they were having deep visceral pain, where we're doing an exploratory of some sort, really getting in there and they're very painful, they need to be in stage 3, plane 3, which is a deep anesthetic. So we need to be really careful with this stage because all the muscles are really relaxed. The ability for them to maintain respirations is also in danger because their intercostal muscles are really relaxed, if not paralyzed, and they're going to need help breathing. So you're going to go ahead and assist them with breathing and bagging them, and make sure that they stay oxygenated during this plane. You're also going to lose one last reflex. It might be slow or absent, which is the PLR. So you shine a little light in both of the eyes, see if those pupils constrict. If they constrict slow, or it might be absent, that's another way to tell if your patient is really deep. So if there's no PLR, the patient is pretty deep, stage 3, plane 3. So moving on to stage 3, plane 4, which is anesthetic overdose. We are in serious trouble if we've reached this point. We are going to be in really big trouble. We are too deep. We've gone past the point of just deep anesthetic, and we've reached anesthetic overdose. So the patient's reflexes are all absent, PLR is absent, and we have either bradycardia and hypotension. So we have a low heart rate and we have a low blood pressure. We're probably hypothermic as well. So a lot of these patients would be like shocky patients that were hit by car, emergency exploratories. They got a little too deep under anesthetic because they weren't doing that well anyway. And now they're in shock, now they're under anesthetic, and they're experiencing an anesthetic overdose. So breathing again, just like stage 3, plane 3, we're going to need to assist with the breathing. So we're going to go ahead and grab our bag and manually ventilate. We're going to watch really closely our end-tidal CO2 and our SpO2 to make sure we're ventilating and oxygenating appropriately so that they have the right saturation and that they have perfusion to their organs. It's a dangerous level, so that level you are walking the border of anesthetic death. So our last stage, towards the end here, is stage 4, and that is anesthetic, irreversible anesthesia. So patient has become way too deep. They are experiencing immediate death. So 1 to 5 minutes, depending on the patient. This is the point where you're doing CPR, but you're not getting them back. All of the isoflurane should be turned off. The ventilating should be turned up. The life-saving measures have already been introduced. So we're doing our CPR, we're doing our epinephrine, we're doing our atropine, we're reversing some drugs. We're trying our hardest to save this patient. But at this plane of anesthesia, plane 4, you probably are not going to get them back. So something has happened that's catastrophic, way too deep, way too long, and they've experienced anesthetic overdose and are heading towards anesthetic death. At this point, the doctor should already be aware of the problem. You shouldn't tell them at this stage in the game. They should already be hearing monitors going off, seeing people fluttering around. The hallmark of stage 4 anesthetic death is we have asystole on the heart rate monitor, which is the flat line. We have a blood pressure that is either low or non-existent, and we have prolonged CRT, if any. So we might have really pale mucous membranes and we're going to have a CRT capillary refill time of 3, 4, if it's even going to be measurable. So respiratory rate, we have none. We're apneic. We're breathing for them at this point, and they are on their way to Rainbow Bridge. So we don't want to reach that point. We want to catch anesthetic overdose before we get there. So we're going to back up a few steps here before the patient was on the table and go over stage 1, which is our induction. And that is going to be our excitement stage, our fight or flight. That patient needs to get out of there, they think. They're experiencing a lot of reflexes, voluntary excitement. They're trying to paddle. They're going to see struggling. You're going to be using your towel or whatever to restrain them on the table, keeping them safe so that you don't get hurt, so they don't get hurt. You're going to see a rise in respiratory rate. They're going to be panting potentially at this point. And you're going to see a heart rate and blood pressure, if you're monitoring at that time, a higher heart rate and a higher blood pressure. So that is your induction stage, where you're just kind of coming into the anesthetic and they're panicking. So we move into stage 2, where they're delirium. They're kind of experiencing some involuntary excitement. We have some reflexes, some muscle twitching. We have a little more struggle, but the voluntary centers and the loss of consciousness is starting to begin. So they're starting to lose control of their body. They're going to start to lay down. They're going to start to be a little more compliant because they're losing consciousness. They may have exaggerated reflexes, and some patients vomit at this stage because of the room spinning and the delirium. They also might become apneic and hold their breath at this point. I've seen that with a lot of patients. You induce with their Tilazol, and then all of a sudden they're in stage 2. At the end of stage 2, stop breathing. So stage 2, towards the end, and stage 3, plane 1, is where we can intubate most patients. So a lot of dogs will be intubatable in stage 2 towards the end. Cats sometimes need a little bit longer because they're just a little more excited, I suppose. So they'll be more intubatable near stage 3, plane 1, where they're going to have a few reflexes present. They're going to have the corneal, the palpebral, probably the toe pinch, the deep pain. So we're going to go ahead and check those reflexes and make sure they're still present to evaluate what plane we're in. And once we've kind of become just smooth sailing, we're going to take them into the surgery room, where they're going to be in stage 2 or stage 3, plane 2. So again, stage 3, plane 2 is where we were at before, and we're just sailing, we're cruising, we're at our good general anesthetic depth. That is where you want your patient to be most of the time, as long as they are healthy, happy little patient. Most patients will do well under stage 3, plane 2. So that is our anesthetic monitoring and how it relates to our patient and how it relates to the reflexes during the stages and planes of anesthesia. Okay, so the last part of this video is going over an anesthetic monitoring form. And this is, again, our patient here that we would have had under anesthetic. And I'm going to go ahead and zoom in so you can see. So using the anesthetic form, about every 5 minutes, we're going to write down the time, heart rate, temperature, respiratory rate, mucous membrane color and CRT, blood pressure, SpO2 or pulse ox, and Tidal CO2, isoflurane level, oxygen flow rate, and the thermal support that we're using. So every 5 minutes for this patient, Cha-Cha, we were writing down our vitals and recording those numbers as we went. So the anesthetic monitoring chart is really important to go back and look at our pre-medications and our inductions that we use. So if next time we need to put this patient under, we know what we used last time and if it went well. So according to these values here, blood pressure remained constant, heart rate was good, not very hypothermic either. So we could use these pre-medications and induction agents again in the future, and it would likely be okay for this patient. So one last bit of here is our anesthetic start time and stop time. We have our surgery start time and stop time, and we have our intubation time and extubation time. So another little part down here, if we need to add any adjunct drugs or emergency drugs, we would write them down here. So we gave this patient a penicillin G injection, and that was 2 mils. down here, so any extra drugs that we administered during the procedure, and any notes that we'd like to put down here. So in this case, it was that we did some 4 dental extractions for this patient. So this is our complete anesthetic record. Up here in the corner denotes that we have logged our controlled substances, which are over here, which would be the Torbagesic that we used. So we did log that. And this record is complete, and that would be how you would use an anesthetic monitoring form during all stages of anesthesia in a surgical patient.